All right, future nurses, welcome. Let's talk about one of the toughest parts of the NFLEX, cardiovascular pharmacology. I know, it can feel like a total beast, right? But don't you worry. In the next few minutes, we're going to absolutely crack the code on the most tested cardio meds, so you can walk into that exam feeling like you own it. So let's just jump right in with a situation I can pretty much guarantee you're going to see.
Okay, let's put you on the floor. Your patient is on the Zinipril, and they hit the call light. They tell you they've got this annoying dry cough, and their tongue feels, well, fat. What do you do first? Come on, put on that NCLEX thinking cap.
If that question made you stop and think for a second, that's exactly the point. This is a classic high-stakes NCLEX trap question. It's specifically designed to see if you just know the textbook stuff or if you know what your actual priorities are as a nurse. And mastering those priorities, well, that's exactly why we're here.
To handle situations like that, you gotta have the right tools in your toolkit. So we're gonna break down the biggest, most common drug classes into a really simple, high-yield guide you can use to immediately recognize any cardiomed they throw at you. The secret weapon here is all about pattern recognition. Seriously, the NCLEX doesn't expect you to have every single drug memorized, but they absolutely expect you to know the class by its suffix. If it ends in pril, like lisinopril, you're thinking ACE inhibitor. If it ends in olol, like metoprolol, that's a beta blocker. And if you see diapine, like amlodipine, you're looking at a calcium channel blocker. Knowing these endings is your first and biggest shortcut. It's like a cheat code for pharmacology. All right, let's walk into what I like to call the minefield. This is where the NCLEX really lives and breathes. It's not just about what a drug does, it's about what you do when things go horribly wrong. These are the life or death adverse effects you absolutely have to know. And that brings us right back to our first and most critical safety alert. Remember that fat tongue from our first question? Well, that's angioedema. It's this super rapid swelling of the deep layers of the skin, and when it hits the tongue and throat, it can literally block off the airway. It's all because of an increase in this thing called bradykinin, and it is hands down the #1 most life-threatening side effect of any ACE inhibitor. So let's be crystal clear about this. Your priority action, the very first thing you do, is you recognize the danger, you hold that next dose of medication, and you get the provider on the phone immediately. This is not just some side effect, it's a potential airway emergency. And that is the correct NCLEX answer 100% of the time. Okay, on to the next minefield. You glance at your patient's monitor and you see this, a heart rate of 48. You check the MAR, and sure enough, they're due for their morning dose of metoprolol, a beta blocker. What's your move? What do you do? The answer to that is an absolute ironclad rule you can never, ever break. Before you even think about giving a beta blocker, you have to check their vitals. I mean, these drugs are designed to lower heart rate and blood pressure. So if the heart rate is already in the tank, we're talking below 50 or 60, or that systolic BP is under 90, you hold that dose. And you call the provider. Safety first, always. Okay, let's switch gears to another massive drug class, statins, for high cholesterol. They work great, but they come with two pretty serious risks that the NCLEX just loves to ask about. First is myopathy. That's muscle pain, and it can actually get really bad and turn into something called rhabdomyolysis, which just wrecks the kidneys. The second big one is hepatotoxicity, or damage to the liver. So because of that risk, the single most important thing you can teach your patient is this. If you have any new muscle pain, soreness, or weakness that you can't explain, you have to call us right away. I mean it. That one little piece of teaching can stop a life-threatening problem before it starts, and you better believe it's a key testing point. Now for an emergency drug, nitroglycerin. When a patient's having angina, that's chest pain, this tiny little tablet they put under their tongue can be a complete lifesaver. It works by opening up the blood vessels to get more oxygen to the heart. But the rules for how to give it are super specific, and you absolutely positively have to know them. Let's walk through this step by step, because this is so important. The second they feel that chest pain, boom, one tablet goes under the tongue. Then they wait 5 minutes. If the pain's gone, awesome. But, and this is the part the NCLEX will try to trick you on, if that pain is not completely gone after 5 minutes, the very next step is always to call 911, period. Then yeah, while they're waiting, they can take a second tablet and 5 minutes later, maybe a third. But that call to 911 after the first dose, that is the most critical safety step. So you've made it through the minefield. Good job. Now let me give you a secret weapon for test day. Some super simple, super powerful mnemonics that will lock this stuff in your brain for good. For all those ACE inhibitors, the prils, all you have to remember the letters ACE. A is for angioedema, our big, scary, life-threatening airway emergency. C is for that persistent dry cough, which is really annoying but not actually dangerous. And E is for elevated potassium, or hyperkalemia. It's a dead simple trick to pull up those top 3 side effects when you're under pressure.
Okay, it's time to put all this together. Let's see how you do on a quick final challenge. You ready for this?
So here's the deal. Your patient takes their first dose of nitro. 5 minutes go by. They tell you, it's a little bit better, but the pain is definitely still there. What is the absolute 100% correct next action they need to take? And the correct answer is they call 911. This is such a common NCLEX trap. It does not matter if the pain is slightly better. Any chest pain at all that's still there after 1 dose of nitroglycerin has to be treated like it's a heart attack until you can prove it's not. Safety is everything, and that means you get help on the way, right now. Fantastic job. Let's lock all of this in with a final, super fast, rapid-fire review of the absolute must-know facts.
First up, angioedema. What is it? That life-threatening airway swelling from an ACE inhibitor. Your priority? Hold the med, call the provider. Done.
Next, the beta blocker rule. You hold it if the heart rate is low or the blood pressure is low. What's your priority? You check those vitals before every single dose. The nitroglycerin rule. What's number 1? You call 911 if any pain is left 5 minutes after that first pill. Your priority is pure and simple. Patient safety. It could be an MI. And last, the statin alert. The big risk is myopathy, right? So your priority is teaching. The patient has to know to report any unexplained muscle pain immediately. Okay, so you've totally nailed the rules for each drug class. But let me leave you with one final thought to chew on. What happens when your patient is on both a beta blocker and a calcium channel blocker? I mean, they both can drop the heart rate and blood pressure. So what becomes your priority assessment then? That, my friends, is that next level of clinical judgment. Keep digging, keep asking questions, and you are going to crush this exam.